Bone marrow transplantation in lymphoma is usually indicated when patients have a recurrence. Now, depending on the type of lymphomas and the number of recurrences that the patient has had, we decide to go for either an autologous bone marrow transplant or a allogenic bone marrow transplantation. In certain situations, as in when there are high risk lymphomas, we also offer autologous bone marrow transplantation upfront. There are indications like mantle cell lymphoma and T cell lymphomas where autologous transplantation is offered in the first line of therapy. Bone marrow transplantations are essentially of two broad types. One is called the autologous bone marrow transplant, where the donor is the patient himself, and allogenic bone marrow transplant, where we collect cells from a healthy donor. In autologous bone marrow transplant, which is by far the most common bone marrow transplantation we do in lymphomas and in another hematological cancer called as myeloma, the patient himself is the donor. Now, why do we do autologous bone marrow transplantation? Here, the intention of doing autologous bone marrow transplantation is as a principle of consolidating the treatment that the patient has received prior to transplant, which means that patient would have received chemotherapy and the disease has been brought to a reasonable control. And the purpose of giving autologous bone marrow transplant is to deliver effectively a very high dose of chemotherapy to potentially remove whatever residual microscopic cells of cancer that are left in the patient's body. Now, delivering such high doses of chemotherapy entails severe forms of adverse events or side effects because of chemotherapy. To mitigate this, in part, is to store the patient's own stem cells before giving the chemotherapy and then returning these stem cells to the patient as a blood transfusion after chemotherapy has been delivered. This prevents severe life-threatening marrow suppression and risk of infections and life-threatening complications to the patient by more than 95%. In allogenic bone marrow transplant, we have two intentions. One is to consolidate the patient's treatment by removing the residual cells by delivering a high dose of chemotherapy, and also expecting a graft versus leukemia effect or graft versus tumor effect by the incoming donor cells. Now, that's not possible with the patient's own cells. In such situations, we need healthy cells, and that comes from a healthy donor who is matched with the patient. Now, once the patient has undergone a successful bone marrow transplant and does not develop any significant side effects of bone marrow transplant, he or she essentially can lead a normal life. However, you should remember that periodic checkup and reviews by the treating team and the transplant physician is necessary. In our practice, we have seen some of our post-transplant patients who are actually fitter than us in life as well as in activity. So that should not stop a patient from pursuing bone marrow transplant if it is required to cure or treat her or his condition.